Okay, I'm going to show about the examination, abdominal examination of the obstetric patient. Obstetric patient is a pregnant lady. So when you see that this is a pregnant lady, it's a mannequin. So when you see the pregnant lady, you have to see the inspection, do the inspection and palpation. So for the compared to the gynae there is a percussion or percussion, but in our obstetric there is no percussion. So only you need inspection, palpation, and then auscultation. So when you do the inspection, you see the abdominal distended. So we need to make sure we need to take note abdominal distended. How do you know it's an obstetric case? You need to find the linea nigra. There will be the linea nigra, the black color line in the middle of the middle, running from the umbilicus to the symphysis pubic. This is a linea nigra. And then there might be the striate gravidarum. Some of the patients do not have gravidarum, but some are yes. And then there will be another striate apical. So striate gravidarum and linea nigra are the pregnancy features because of it's a pregnancy feature. Striate apical is a previous pregnancy. And then you have to find for any other scars, any midline scar, right paramedian scar, or laparoscopy scar, or low transverse scar, previous cesarean session. This all you need to find out. And then if you see the fetal movement, you can mention that you can see the fetal movement is seen or noted. If nothing, you can omit it. After that, you need to go for palpation. Your palpation, yes, in a gynae patient, your palpation is normally we do it for the 9 area, abdomen, all this 9 area we palpate it. But in obstetric, yes, you can roughly put your hands on or palm side of your finger, your hands on your patient abdomen. Then you want to make sure that the abdomen is soft and non-tender, because some of the pregnant abrasive placenta case or uterine rupture case, abdomen will not be soft. So you need to make sure abdomen is soft and non-tender. Then after that, you need to find the clinical find the height. So first, you have to go for CV scanner. The moment you put the ulnar border of the hands, the moment you hit the resistance or the firm consistency, because abdomen is soft. The moment you hit that one, it is your fundus. So straight fundus, clinical find the height. Clinical find the height, we take note from the CV standard is there. CV standard level is 36 weeks, so 2 centimeter below is there. One finger around below is 34 weeks, then 32, 30, so up to 20, umbilical above is 24 weeks, at the middle is 22 weeks, at below of the umbilical is 20 weeks. So there you have to go, this is clinical find height. Then symphysis find height is, you have to put the measuring tape in the symphysis pubic, then you follow that, you bring the tape to the CV standard, then you have to check for the, and with the centimeter side, not the inch side. So that after that, with the inch side, then below is a centimeter side. So after that, you open it and you see there how many centimeter of this gravid uterus. So that is approximately normally 34 week will be equivalent to the 34 centimeter. But if the patient is having if the patient is obese woman, you may get the most invasive find height because of you have to check for the fat the fat will be included in our symphysis find height measurement. Okay, then after that, this clinical find height and symphysis find height has to be corresponded to the period of amenorrhea. So if patient is 34 weeks, period of amenorrhea, then if clinical find height and symphysis find height is 34, then she is corresponded, uterus is corresponded to the date. If the clinical find height and symphysis find height is more than the period of amenorrhea, it is a uterus larger than date. Smaller is uterus is smaller than date. So that is how we estimate the baby size or any macrosomia, any polyhydramnios. In a multiple pregnancy, it will be bigger. Uterus is larger than the date. After that, you need to find for the find grade. So when you go for find grade, you go from the side way, and then you have to go at the finder. So at the finder, you have to try, if you can feed the fetus part, you need to find out, is it the soft, broad, like a breech, or is it the round and hard and the palatable? So normally head will be round, hard, regular, and palatable. So when you press on this side, there will be, you can palate the head. If it is better, it will be soft, broad, and irregular. You cannot palate it. So normally it's a longitudinal line, cephalic presentation. Cephalic presentation means head is here. So you may find the paddock in here. Sometimes you can find a bridge presentation, so head will be here. So that is how we check for the find grip. After that, you can go for lateral grade. Lateral grade means that you have to stabilize the one side of the fetus, this side. Then you press on there, another left side. Then you have to stabilize this side, the right side. You pop it on the left side, and you have to find, is it the back or the fetal limb. Normally back will be smooth, curved and continuous, and normally it's a less emptiness. After you finish the left lateral grade, you press on this area, stabilize, and you check on this side. It will be is there any the knobbling sensation, or is there any emptiness? Normally emptiness is a fetal limb. So if this is a back, this is a fetal limb. If this is the back, this will be the fetal limb. So after the left and right, you have to go from there, the pelvic grade. So pelvic grade means that you go from the left and right, and then you go to the pelvic side. So when you get on the head, when your fingers are at the symphysis pubic level, if it is a cephalic presentation, you will find it hard and round. So when you get it, you can try to block. Then you try to put your hands here. Then you have to put your forefinger in there above the symphysis pubic. So if your head is more than 4 fingers, that means more than another one more finger, 5 fingers, then it is 5 feet above the pelvic brain, which is totally floating. The baby head is floating. If the portion of the head, which is above the symphysis pubic, is equivalent to 4 fingers, it will be 4 feet palpable above the symphysis brain. If 3 feet, 2 feet is equivalent to the engagement. So if you can find the only fetal part is 2 feet only, the 3 feet of the fetal head is inside the pelvic cavity, it is the engaged fetal head, which is normally seen in labor. Okay, then after you finish the engagement, presentation, line, longitudinal line, and then only you need to you finish the palpation. Supposing if the baby head or buttock is not in this area, in this suprapubic area, then you need to find in the left iliac fossa, right iliac fossa. If you can find one presentation, one head or buttock here, another you have to go for opposite side. Then if it is confirmed, then it will be oblique line. So where is the head, where is your buttock? You have to explain. That is same thing to the LIF region. Where is the head, where is the buttock? This is for oblique line. Oblique line, there is no presentation because there is no fetal presenting part nearest to the internal cervical. So this is no presentation. For the, if you cannot find anything, you have to find for the transverse line. Transverse line, the head will be either here, right lumbar, or left lumbar. The opposite will be the buttock. Then the back, you have to find where is your back. So the back may be either facing upward to the maternal symphysis or backward to the maternal symphysis pubic. That is for transverse line. After you get the line, then you need to go for the auscultation. So you need to find the back. Supposing back is here, head is here, you need to find the anterior shoulder must be here. So you put on the spinet fetal stethoscope on anterior shoulder, and you have to listen to that. When you listen, you need to hold your mother's hands. Try to measure the maternal pulse rate. So you have to listen like this way, so that you listen to the heartbeat, feel the heart sound, and you are pressing on the mother's hand, so that you are trying to, if not synchronized, this is the fetal heart. If synchronized, you are listening to the maternal heart sound, maternal heart, the heart rate from the superficial artery. Then after that, if you're talking about bridge, also same thing. If your head is here, back is here, you need to listen to this side. If the patient is far from you, you can ask the patient to come move forward to you, and you can listen clearly. If you cannot hear the fetal heart sound by the fetal stethoscope, you need to get either ultrasound or Depto, handheld Doppler. You can listen to that. And then if the transverse line, yes, back is here, you have to put it here, back is here, is here. Normally abnormal line and abnormal presentation, which is pre-presentation, or transverse line and stable line, transverse line or oblique line, it will be a bit difficult to get the fetal heart sound. However, you have to try to listen to the fetal heart sound. Then after the auscultation, then you can estimate how is the baby size. So if the baby is this longitudinal line, you need to put it like that, and you need to estimate. It's estimation, so it can be wrong. So to get the proper accurate body weight, you need to check by the ultrasound for the estimated fetal weight size. But in palpation alone, we can get the rough idea of the uterus larger than date or uterus smaller than date. So if the baby is growing or not growing, we can or is growing too much, then you can get the estimation by the abdominal examination. And then after the liqua volume, is it liqua amount is normal or not? If the liqua is increased, you when you do the palpation, the baby will be floating here and there, so it's very difficult to get the palpation. When you listen, also difficult to get the fetal heart sound. But when you are oligohydramnios, is the whole uterus is tight with the baby fetus, so there's less liqua, so it's very easy to find the fetal parts, and then fetal presentation and line, and then auscultation also will be easy. So that is the abdominal examination of the obstetric patient.